Okay. In the modern evaluation of congenital heart defects, three major non-invasive modalities are used: echocardiography, MRI, CT angio. And echocardiography is the main tool in cardiology. It is available cheap without radiation. Give us option to see well the intracardiac anatomy with high spatial resolution and good temporal resolution. Although it's an advantage, this modality has its limitation in which the CT and MRI come to solve. So MRI. The MRI gives us good view of the anatomy. In the next slides, I will show you a few examples. Here you can see this is a double turbospin echo, black images, so double AR is the same synonym for the same thing. It's a well demonstrated blood vessel in the areas in black. We can see the aortic arch, and the arrow shows us aortic coarctation. Vascular ring, Professor Heron talked a lot about the vascular ring, but just a few examples in the CT and MRI view. This is the right aortic arch with aberrant left subclavia causing a vascular ring. You can see this is the right aortic arch here, and this is the aberrant left subclavian. And if you look at the MPR, you can see the pressure here on the trachea in the coronal view and the sagittal view here. This is an example of aortic coarctation. You can see the collateral, and here you can see the coarctation here. Another example of coarctation, you can see quite well the coarctation here. Another way to demonstrate the anatomy and function is to use the dynamic sequences. We are able to estimate the anatomy in systole and diastole. This is a case of a four-chamber view. You can see here there is a left ventricular aneurysm here, and this is a pericardial effusion. In this case, you can see the ASD secundum. You can see the flow across the ASD here and here. Function. The estimation of function in MRI has become the gold standard. The results are very accurate and they are reproducible, which is good for follow-up. We use a few planes in order to get the SAO. This down here is the SAO. And from the SAO, we calculate the function. We use some contour in systole and diastole, and we get the stroke volume, the function, and the end diastolic volume. Flow evaluation. Sorry. Okay, with the flow sequences, we can estimate the flow across the valves, blood vessel, and the degree of shunting. This is very important in pediatric congenital heart defects. Tissue characterization. We can characterize cardiac tumor, myocarditis, and infarct. We can also estimate the level of iron using the T2 star sequences in patients receiving multiple blood transfusion due to systemic disease like thalassemia and aplastic anemia. So what is the disadvantage of MRI? Duration of scan. It takes a lot of time to position the patient and to start the localizing sequences. This should be taken into consideration, especially in patient that is not stable. Spending time out of the intensive care unit might be dangerous for them. We do not scan children with pacemaker. Device like stent or occluder will produce an artifact, high cost and limited availability. We need also to do long general anesthesia or long sedation. It's limited in the evaluation of airways and lung. So what is the advantage and disadvantage of CT angio? Oops. So the scan is very fast. The scan itself can take less than half a second. Very high spatial resolution, slice thickness about 0.625 millimeter. Less limitation for devices as they will create less artifacts. Short sedation instead of long general anesthesia. Airways and lungs are well demonstrated. High availability in our institution. So what is the disadvantage of CT angio? The contrast agent is iodine-based. And this is very important in patients with urinary dysfunction with high creatinine level. New machine allowed us to reduce the contrast dose and still get same quality. Ionizing radiation. In the last 10 years, there has been tremendous drop in the level of radiation. Today, with new machine, we are able to get high-quality images with radiation dose of 0.18 millisievert, and I will talk about this later. Static images most of the time, and I will refer to that also in the end. Before scanning, we use short sedation or short anesthesia for all of our patients below 5 years old in order to achieve better image quality. We use axial scan technique with iterative reconstruction in order to reduce radiation. We use IV access of at least 22 gauge catheter or larger. Injection rate will be about 2 milliliters per second. We use ECG gated. We use systolic phase of 40, 45, and 50 of our interval. Ventilate patient can be paralyzed and ventilation discontinue for a few seconds in order to avoid breathing motion. In these cases, we need to use positive end expiratory pressure in order to avoid tracheobronchial tree collapse. This is an example because about the radiation, I wanted to bring this example. The heart rate here was 136 beats per minute, and the total DLP is about almost 4.7 DLP. So calculation of radiation dose here will be, the DLP is multiplied by fudge factor for infant and small children. So the total dose radiation is 0.18 millisievert. Just to remind you that 0.02 millisievert is equal to 1 chest X-ray. So the total dosage was about 9 chest X-ray for all the scan of the chest. At most 10% or less than what infants receive in cardiac catheterization. And this is the image quality that we get. Examples. So in this case, what we can see, this is the right ventricle, this is the left ventricle. We can see this is the aorta arising from the right ventricle, and the pulmonic is overriding on the VSD here. If we look carefully, this is the aortic arch, and you can see here that there is a interrupted aortic arch here. This is in color Doppler mapping, and this is with 2D. You can see there is a interrupted aortic arch. So the diagnosis is Towsing big anomaly. In Towsing anomaly, the aorta arising from the right ventricle, and the pulmonic is overriding the VSD. Or in different word, it's transposition of great artery with a subpulmonic VSD. So this is the CT angio here, and you can see this is the pulmonic overriding on the VSD here. This is the aortic arch with interrupted aortic arch here. You can see this is the arch arising from the right-sided right ventricle, and the pulmonic is overriding here. And in volume rendering, you can see this is ductal arch. This is not the aorta. The aorta is here, and you can see the interrupted aortic arch. And we swivel around, you can see it quite well. So the type of the interrupted aortic arch is, of course, type A here. Another example showing us communication between the aorta and the pulmonic here. And the diagnosis is the aortopulmonary window, which is congenital communication between the ascending aorta and the MPA. This is the chart showing the AP window. So you can see this is normal, and this is the communication between the aorta and the pulmonic. This is the pulmonic, this is the aorta. And this is in volume rendering, you can see here, this is the pulmonary artery, this is the communication here, this is the aorta here. In the axial stack, you can see here the communication, this is the pulmonic, this is the aorta, and here, this is the communication here. But this is not done because the patient has also aortic coarctation. You can see it well here, yes, or in MPR, you can see it here. Another case of a total anomalous pulmonary venous drainage infracardiac. Here you can see this is the pulmonary vein in the chart. This is the vertical vein, and this is the IVC. In our case, you can see this is the pulmonary vein, this is the common vein, and this is the vertical vein. We can easily get inside and see the communication of this vein to the hepatic vein. This is another case, the same case with swiveling. Next case, of course, will be total anomalous supracardiac. This is the pulmonary vein here. This is the vertical vein, and this is the innominate vein. This is the SVC, and this is in real life. This is the innominate vein. This is vertical vein here, going down, and we can see the common vein here, and the pulmonary vein will enter to the common vein here. You can see it here and here. This is in volume rendering from the front, from the AP. You can see this the vertical vein, nominal vein, and the SVC. It's very easy to see the pulmonary vein entering here to the common vein. This is the vertical vein. And we can seeing well all the anatomy. In this case, you can see this is the aorta, which is overriding with aorto-mitral discontinuity, which means it's like a double outlet right ventricle fallow type. You can see here the aorta almost rising totally from the right ventricle. This is the pulmonic and this is the aorta. So the diagnosis here is a double outlet right ventricle fallow type. And we know that about 5% of these patients have anomalous coronary artery. On echo on this child after birth, of course, we suspect that the origin of LAD is from the right coronary. So we do the CT angio. This is what we thought that we saw in echo, that the LAD arising from the right coronary. This is the overriding aorta. And this is the right coronary, a little bit clockwise rotation, which is typical for fallow. And if we look, this is the RCA and this is the LAD. You can see this is the RVOT, this is the RV outflow tract here. So the LAD here is crossing the RVOT, is the same. This is the right, this is the LAD, and this is the RVOT. So why this important information? In the etiology of fallow, if the pulmonary valve area is very narrowed, a transannular patch will be needed. In case of anomalous LAD, this procedure will cause damage to the LAD. So we'll need an homograph instead of transannular patch. The surgeon will therefore need to be prepared for this option in advance. Aneurysm of Kawasaki disease. Kawasaki disease is one of the most common pediatric acquired heart disease. We don't know the etiology for Kawasaki disease, but we do know it can cause coronary aneurysms. Here you can see the coronary, the right coronary with aneurysm here and aneurysm in the distal part. This is both sides. You can see both sides are affected. Also the left side affected, the left coronary affected. And this you can see from another view that we have aneurysm in the proximal part and the distal part here. Vascular ring, most of the thing Professor Heron talked, but we show you a little bit the same patient with the pressure on the trachea here. And we can see here, this is the left arch and this is the right arch here. And we can swivel to us to see exactly the area of the narrowing. You can see it here. And in axial, you can see this is the trachea. You see how narrow it is and become almost disappear. The trachea disappear in the area of the vascular ring. This is very severe tracheal narrowing. We can also use by the CT doing virtual bronchoscopy. This case is a double aortic arch with left arch atresia. You can see the atresia is here. Also, Professor Heron showed a few images about this. Here we put the trachea inside. You can see in the area of the ring here, there's a narrowing of the trachea here. You can see it quite well in the same place that the ring is crossing, so it makes a pressure on the trachea. We can do a virtual bronchoscopy. Here, this is the area that looks with pressure from the vascular ring. If we're going inside, we actually see exactly the area that there is a pressure. And we're crossing this area and then it's totally patent. Okay, ventricular function, I show kind of most of the time. When we need to evaluate the function and patient has contraindication for MRI, we can use 10 phases of scan between systole and diastole. The image quality is good, but the price is radiation dosage. So you can see it here. This patient has pacemaker wire here. So we cannot put the patient in the MRI because it's a magnetic field. And what we get, we can have the function. As I told you before, the price is radiation dosage, 10 times more. I would like now to talk about the virtual PM in congenital heart defects. The diagnosis of congenital heart defect in utero is challenging. The diagnosis affects the family and the fetal life. Based on the diagnosis, parents can decide whether or not to terminate the pregnancy. In termination above 20 weeks of pregnancy, we are able to perform virtual PM. In the same manner, we can perform virtual PM on newborn who succumb in the first day after birth. The majority of diagnoses made before 20 weeks of pregnancy. Some cases are complicated and need further evaluation to assess the severity of the malformation. The minority of congenital heart defects are diagnosed after 20 weeks of pregnancy. In the case of termination after 20 weeks of pregnancy with cardiovascular anomaly, virtual PM was performed. All families signed informed consent for virtual PM. We explained the family about the process and we promised not to cause any damage to the body. There is no religious, actually about the Jewish part, contraindication for virtual PM. Imaging option, MRI and CT angio. We know that CT angio is much more available than MRI. It takes seconds to finish the scan. In MRI, we can demonstrate well or better the ventricle, and if there is no patent ductus arteriosus, it is almost impossible to demonstrate the pulmonary artery tree. So this is MRI virtual PM, and this is CT angio. We actually can get inside to the vascular tree inside. So how can we inject contrast? This is one of the common questions people keep asking us. So soon after death, DIC begins. There's almost no clots in the vascular system, except in the ventricle, which contain a large thrombi. We are able to use umbilical vessels which stay patent and inject them via long catheter. We use both umbilical vein and artery. We inject mixture of iodine, contrast, saline, and polyethylene glycol. We scan 3 times without contrast, venous injection and arterial injection. What would we expect to see? We can well demonstrate the blood vessel and the relation between them. We are able to show narrowing blood vessels, systemic vein, pulmonary vein drainage, atria and ventricle partially. Limitation. It is difficult to pass through the ventricle with contrast due to thrombus clot in the ventricle. In malformation with no patent ductus arteriosus, it is problematic to demonstrate the pulmonary tree with CT angio. And MRI in this case may be better option. We divide the patient into 4 groups: pulmonary complex, aortic arch anomaly, conotruncal anomaly, and others. Few examples. Suspected hypoplastic lung at 18 weeks of pregnancy. Re-evaluation 22 weeks of pregnancy showed the same finding. She was referred for termination. So this is how we get how it's looked, the images, the volume rendering. You can see here, this is the MPA ductus, and this is the pulmonary artery. You can see in axial MPR, you can see this is the MPA, this is the LPA, and this is the RPA, which is narrowed. If you look inside, you can see this is the RPA, this is the LPA, and this is the MPA here, and this is the aortic arch. You can see it here in another volume rendering that this is the RPA and this is the LPA here. The pathology showed the same finding, confirm our diagnosis. Another case of prenatal diagnosis of small mitral valve, small LV, suspected tubular hypoplasia of the aortic arch, change in chromosome 22, termination once done after 26 of pregnancy. Here we can see there is a lobster hand. And if we go inside, we see there is an absent radius here. See, this is only the ulna. The radius is missing. And about the heart, you can see this is the ductal arch, and this is the aortic arch, and there is a coarctation here. In volume rendering, you can see it here, the narrowing of the arch. The next case is about transposition of great artery. In transposition, we have the aorta arising from the right ventricle and the pulmonic arising from the left ventricle. So if you look here, this is the aorta and this is the right ventricle and this is the left ventricle. So if we're going and just take out the aorta slowly, you can see that the pulmonary artery arising from the left ventricle here, and this is the pulmonary artery bifurcation. Okay. This is a case of 24 weeks of pregnancy with diagnosis of complex congenital heart defect. There was not full agreement about the defect. We can see that the pulmonary artery here is not arising in both diagnoses from tetralogy follow pulmonic atresia and truncus arteriosus is not arising from the right ventricle. In follow, it's arising from the ductus arteriosus, and in truncus arteriosus, it's rising from the truncal arch. So she was referred to termination, and this is the MPR volume rendering. And what we find actually is that this is the aortic arch, this is the overriding aorta, this is the left ventricle, and you can see that the pulmonary artery is coming from the ductus arteriosus. So the diagnosis here is the tetralogy of Fallot pulmonic atresia with good size of pulmonary arteries. The next case, anomalous pulmonary venous drainage. She was on 24 weeks of pregnancy, was suspected partial anomalous pulmonary venous drainage to the azygos vein. She was examined by few pediatric cardiologists and several gynecologists with suspected anomalous lower right pulmonary vein to IVC, scimitar-like syndrome, and no full agreement about the left pulmonary venous drainage. Due to the complexity of this malformation, the family decided on termination. So here we can see this is the pulmonary vein. This is the left ventricle, this is the right ventricle, this is the right atrium. So here we can see that the pulmonary vein from the left side, these are the pulmonary vein, are not going as we expected to the left atrium. Secondly, this is the azygos vein here, and you can see that the pulmonary vein, something is entering to the azygos. Nothing should come to the azygos vein, and this is also pulmonary vein. Okay, this is the volume rendering of this virtual PM, and now we're going to talk separately. This is how we can look about scimitar syndrome. You can see that the pulmonary vein entering to the IVC, and this is what we find here. This is the pulmonary vein, and this is the IVC. So we have one pulmonary vein that's going to the IVC here. Second one, this is the azygos. You can see this is the SVC. So this is the azygos vein. And this is the pulmonary vein that's going to the azygos vein. And third, these are pulmonary veins that going to the right atrium and the area that the IVC enter to the right atrium. So the diagnosis is total anomalous pulmonary venous drainage, mixed type. She was also referred to PM, and the pulmonary vein were not examined, unfortunately. Conclusion, we are able to demonstrate congenital heart defect with virtual PM, especially in extracardiac malformation. Virtual PM can confirm the fetal echo finding. Virtual PM can give reasonable alternative in cases that PM is non-conclusive. It can serve as a good alternative in religious population that refuse PM. Our initial experience shows that virtual PM can play an important role in the diagnosis of congenital heart defect. It is reliable compared to prenatal diagnosis and autopsy. And about the future of all imaging in the pediatric, scanner will be even faster, even lower radiation dosage, less contrast, development of program that will take scan data and improve the reconstructions. This is a fetal cardiac MRI. You can see here, this is the left ventricle, right ventricle. Another example, you can see the fetus here. This is right ventricle, left ventricle. You can see here also the next one, a little bit kind of arch. We still don't have fetal cardiac gating in our institution, but I believe in the next few months we will get in Sheba a new MRI machine that will also contain, hopefully, will include the auto gating. We're using also 4D flow in MRI. You can see with the same scan we can have the anatomy and the flow inside. This is a demonstration of aortic arch. And actually we can use the whole body. We can see with the flow and the anatomy together. These are sequences that already people using over the world. It's okay. Before I'm done, I would like to thank to Dr. Jacobson, who is a friend and colleague and helped me we're doing together all the imaging. Dr. Goiting, Professor Diseni, Professor Konen, Professor Achiron, Dr. Vardi, they help us with all the sedation in the CT, and our great CT and MRI techs. Any question?